we're very fortunate to have my doctor, Dr. Randy Stephenson from the Neurology Center of Fairfax, who's been my doctor for over 20, ever since he started at the Neurology Center, which is it, how long have you been there, Randy?
15 years.
No, that's yeah. I was with you since day one.
Yeah, you have.
So that, uh, and here's Randy's bio. Uh, so, so glad you joined us, Randy. Thanks for being here.
Oh, my pleasure. I think, Carl, you were with Linda Sigmund before me.
I was, but how many years, Angela?
I think we're gonna have to. I think we're approaching 30, so it's
Holy
way too
moly.
long.
That sounds about right.
Yeah,
We don't get any frequent flyer miles either, so
I know. That's just not right.
I know.
But an endless supply of chocolate.
well, thanks, Randy, for being with us today.
Oh, thanks for
Uh,
having me.
So,
So one of the first questions we got was submitted ahead of time was what makes a patient a good or bad candidate for deep brain stimulation?
Oh, that's a great question. Um, so, uh, deep brain stimulation surgery, it's been around. I think when I was training in Parkinson's disease in Philadelphia, they had been doing it at University of Pennsylvania for about 10 years already. And they were one of the first uh, places, medical centers in the country to do it. So it hadn't been around for that long when I started. But it was fortunate because I got to train with some people who had a really good understanding about the what we were looking for in a good DB.
Oh, oh, not sure what just happened. Whoop. Sorry, Randy. Hold on. Somehow you got muted. Hold on a second. We lost your audio. Can you hear? Can you hear?
How about now?
Yeah, you're good. You're good.
Sorry about that.
Oh, that's okay.
How long did I go on for?
I
Uh,
think you were talking about Philadelphia,
okay.
and so pick up
Yeah,
where.
so I'd been in Philadelphia and they'd been doing it at University of Pennsylvania for about 10 years when I was training there. And that was over 15 years ago. And it was fortunate for me to be able to work with those folks who were doing it from the very beginning, because I really got, a good education in terms of figuring out who is a good candidate for DBS and who is not. And I think the important thing to walk away with this is that the majority of people who have Parkinson's will either not be a good candidate for it or have no need for deep brain stimulation surgery. And then there's folks who just flat out, regardless, are never going to want to have brain surgery. But in terms of what you should be looking for as a doctor in terms of figuring out who, whether or not somebody should be considering or would want to consider DBS is a severe tremor that does not respond to medication. Um, Tremor is one of those symptoms that it's it's unpredictable how someone how how someone is going to respond to the medication or any oral medication for Parkinson's. So some folks, you put them on dopaminergic medication or you put them on amantadine or whatever, and they respond right away and their tremor gets better. Other folks, you try everything in the arsenal and there's just no response whatsoever. And then there's folks that are in between there. Um, and for some folks who have really bad tremor that doesn't respond to medication, they are bothered enough by the tremor that they are willing to do just about anything to alleviate that symptom. And then there are folks who have really bad tremor, but they just aren't bothered enough. But they can keep it in the on the back burner, so to speak. So that's one symptom. And tremor does tend to respond exquisitely well to DBS. Another symptom is severe dyskinesias. So dyskinesias are those wiggly movements that folks who have had Parkinson's for a while and have been on dopaminergic medication, usually levodopa, for a while. It's those sort of wiggly random movements which is different from the tremor, which is not random. Tremor tends to be very focused and almost not, I wouldn't say stereotyped, but it's a, very, very specific localized symptom, whereas dyskinesias can be more generalized. And folks who have prominent dyskinesias can consider deep brain stimulation as a way of alleviating that symptom. And the DBS can improve upon the dyskinesias either by the stimulation itself, decreasing the dyskinesias, and or the fact that once you get DBS, usually you're allowed to come down on your medications, not off your medications typically, but usually we're able to decrease the amount of levodopa people take once they get DBS. And then as a result, the dyskinesias tend to decrease and in many cases kind of go away. So that's the second indication. And then the third indicator is motor fluctuations in response to the DBS, or I'm sorry, in response to the dopaminergic medication, where the medicine works really well and then it wears off either predictably or unpredictably in between doses. And then patients will have periods of what we call on time, where they're doing great, the meds are working great, and then they have a lot of off time where even though the medication is in their system, they can't, it's like it's not doing anything. And DBS, that's one of the main reasons that I refer people for DBS who want to consider it. So the DBS can smooth out those fluctuations and really increase the on time that people have. So those are the three reasons that someone may want to consider DBS. But you also have to keep in mind there's no absolute guarantee that it's gonna do what you hoped it could do. Although I will say, if you are careful about picking the right candidates for the surgery and you send them to a good, experienced neurosurgeon, the vast majority of time it's helpful. The other thing I just want to iterate, and this is something that folks need to understand, that you want to manage expectations when you refer somebody for this brain surgery. The symptoms are not going to all go away. And it's not uncommon in my experience for people to go in, commit to the brain surgery, thinking that, all right, I'm going for brain surgery. If I'm going to do this, the symptoms are going to all go away. Why else would I do this? And we try to manage that expectation, but that's not the case. Your symptoms are probably not going to all go away, and you're not going to be able to come off of all your medication. And so you need to have that expectation. And the last thing I want to iterate, and this is very important because there's a lot of misinformation out there when it comes to DBS, and that is DBS treats the symptoms of Parkinson's disease just like medications treat the symptoms. It does not treat the disease. So it does not slow down the progression of the disease. You may be functioning at a higher level throughout the course of the Parkinson's than you would be without the DBS. And I've got my arm like this because this is like the slope of the line of progression. So functionality, being on this axis, and then time being on this x-axis. As time goes by, functionality slowly, declines. And this is the slope of the line. Without DBS, you get DBS, the line hopefully gets shifted upwards, but that angle does not change, if that makes sense. And I'm sure that it's kind of a difficult concept to articulate, but it's something that you need to understand if you want to consider DBS.
Randy, that brings up a question. When I used to hear that to be a candidate for DBS, depending on how your best day with Cinemet, it would be a criteria to maybe how well you're going to do on DBS. Is that still the same criteria?
You mean when you're having a good on day,
Yes.
you're doing well?
Yeah.
Yeah. So, yes, that's a good point that I left out. So, DBS, the goal is to get your symptoms controlled to the level that they get controlled when the levodopa is working well. And with the exception of tremor and dyskinesias, if you have a symptom that is not responding to levodopa, again, except for tremor and dyskinesias, if you have a symptom that the levodopa doesn't seem to touch whether or not it's working or whether or not you're on, the DBS isn't going to help that symptom either. So, for instance, if you freeze a lot, or a better example would be if you have a lot of balance problems, and it doesn't matter how on you are and how well the levodopa is working, you're still having problems with falling or losing your balance, doing deep brain stimulation surgery is not going to help your balance. And you do not want to go into that. You would not want to go into that surgery thinking, all right, I'm doing this because I want to stop falling. That is not an indication for the DBS. And it's important to be aware of that because I think sometimes people get misled, by the information that is out there, and you see commercials for DBS, and that stuff isn't going to work, or it's not going to improve with the surgery.
Speech as well, right?
Good question. Speech is one of those things that actually can be made worse by DBS. I've definitely seen it. It classically can get worse if you do the deep brain stimulation for benign essential tremor, which is a separate condition, not really related to Parkinson's disease, but it's the other condition that we commonly refer patients for the surgery, where speech can get profoundly affected by the surgery. And you really have to educate patients about that before the surgery. Usually you can work around it by adjusting the settings on the stimulator, but it can definitely be impacted. The target for essential tremor is different. The target in the brain for DBS is different for essential tremor than it is for Parkinson's disease, usually. But I have seen folks with Parkinson's get worsening speech. It's not typical, but it can impact your speech potentially in a negative way. But the most important thing, though, to keep in mind is one thing that can happen with Parkinson's and DBS is the DBS can have a negative impact on your cognition. And that's why anybody that we're considering sending for surgery, for deep brain stimulation surgery, we have them undergo intense formal neurocognitive testing just to make sure there's no significant issues with short-term memory problems. Your cognition isn't going to be perfect because Parkinson's affects thought processing, executive functioning, attention, that sort of thing. That's okay. But if you have a short-term memory problem, which often is not related to the Parkinson's, but if you have that, DBS is not a good idea because the DBS can make that worse.
Our next question, Randy, was about nutrition.
Mm-hmm.
The person asked, does it matter when you eat in relation to taking your meds and why?
Good question. So I was taught while I was training that, for the most part, it doesn't matter, when people eat and when they take their levodopa. The other medications, it usually doesn't make a difference. And that made it easy to prescribe levodopa because, it's already hard enough to take a medication multiple times a day. And then if you have to time it so that you're taking it on an empty stomach, that makes it even more difficult. And as frustrated as it seems like I get with patients who take it on a full stomach or don't pay attention to that, I can't imagine how hard it is to manage that aspect of it. But at any rate, so that's how I was taught that it didn't really matter. And then when I got to Neurology Center of Fairfax, Linda Sigmund, who brought me down here from Philly, I noticed she was very adamant about you have to take this medication on an empty stomach. You have to take your medication on time, and you need to wait at least an hour after you take your medicine before you eat, particularly if it's protein. And if you eat something that's got protein in it, then you've got to wait 2 hours before you take your medication. And she was I mean, Carl, you know, she's from the army, man. You didn't mess with Linda when she told you to do something. So, and you still don't. Every time I see her, she's the boss. So, at any rate, I started to realize she was right. Um, I do have a few patients that it doesn't really seem to make a difference. And it's probably just because the amount of levodopa that they need in their system isn't that great. But technically, what happens is protein competes for absorption in the small intestine with the levodopa. And so protein can block that absorption so that when you take the medication at the same time as having a high protein meal, the medicine is not getting in your bloodstream, and therefore it's not working. And for a lot of folks, it makes a huge difference. I had a patient, we had him all set for DBS. He was gonna, I think he was gonna get surgery like a month later. And his wife picked up on something that I didn't pick up on, which was she was like, you know, you are not taking your medication on an empty stomach all the time. And and he was having horrible motor fluctuations throughout the day. And his response to the levodopa was really unpredictable. And that's why we were going to do the DBS. And so she said, you know, why don't we, for the next 2 weeks, just be religious about taking the medication on time and on an empty stomach with no protein in your stomach, you know, around that time. And I mean, the fluctuations went away. And and he didn't need to get surgery. So, um, you know, it can have a pretty profound impact on a lot of folks. I have some folks that don't eat protein at all during the daytime, and then they have all their protein at nighttime. I'm not necessarily advocating for that, but it is something that some folks need to do. And you certainly don't want to protein restrict because you need protein for muscle mass and all that stuff. But
Well, and Randy, Dr. Sigmund was adamant about at least 8 ounces of water with every dose of
yes,
medication because the hydration component
yes,
and making sure it got to the stomach versus getting stuck somewhere along
yes,
the way. Yeah.
yes. And that's true. And that's another thing I don't emphasize enough. A lot of times I'll emphasize hydration, particularly when people ask me about diet, because of the constipation aspect of things and also the orthostatic hypotension aspect of things, where folks, because of the levodopa, when they stand up, they can drop their blood pressure. And so you've got to make sure you're good and hydrated. But the other reason you need to stay good and hydrated is because you want that medicine to get into your stomach and not get stuck on the way down and just sit somewhere in your esophagus
Right.
and not get absorbed.
Right. The next question is about exercise. Exercise is apparently the best medicine. If illness or surgery prevents one from exercising for several weeks, can this be made up physically?
So exercise, routine exercise, and for me, it's how often you're exercising. I don't care as much what type of exercise people are doing, although we're learning that strength training is really, I used to say you need the aerobic exercise, but really, you really need strength exercises as well, which is important for all sorts of reasons as you're aging. Bone mass, bone density is really impacted by strength training. And just strength, physical strength is important for being able to get up and down and being able to maintain balance. But also you need some form of, aerobic exercise, usually in the form of walking. And I tell patients you need to do it at least 4 or 5 days a week, and you need to dedicate at least 45 minutes at a time to the exercise. The reason exercise is so important, other than it's important for your overall physical health and your overall mental health, is that it is the one thing that we know for a fact slows down disease progression in Parkinson's disease. And so there is a very clear difference between my Parkinson's patients who don't exercise and my Parkinson's patients who do exercise. And so it's important for that reason alone. It slows down progression. And again, as far as I'm concerned, it's the frequency that you do it for and the duration that you do it for.
Got it. Another question that was submitted was about is there a test for Parkinson's disease and Lewy body dementia?
So there is, when I was training in Parkinson's, there was no test there wasn't like a lab or a scan that we could do that would help answer the question, does the person have Parkinson's or Parkinsonism or not? It doesn't show up on an MRI by and large. Some of the atypical Parkinsonisms, those conditions that look like Parkinson's initially but don't behave like Parkinson's does over time, there can be some distinctive MRI features for some of those conditions, but they're not super sensitive and they're not always super specific. So at any rate, so when I was training, it was all based on clinical judgment, which was one of the reasons why it was especially important to see a movement disorder specialist because, you wanted to make sure you got the diagnosis right because it was all based on how does the patient look, on exam, what's their history, how long have they had symptoms for, what are their symptoms, what do they look like in the office, and then in a lot of situations we also depended on how do they respond to medication. Nowadays, we have a couple of tests that actually help us with the diagnosis. One is a DAT scan, which is a special type of brain imaging. An MRI, what an MRI does is it looks at the brain structure and the brain tissue, and it can tell us, has there been some silent strokes? Is there too much water on the brain? Is there a tumor? And there's never a tumor, but That's what an MRI does. And I always want to get the MRI because it's our opportunity to see what your brain looks like. But it's not going to tell me whether or not you have Parkinson's. But now we have this other imaging modality that actually looks at brain activity. So you get injected with a tracer, and that tracer goes up to the areas of the brain that are affected by Parkinson's disease and Parkinsonism, specifically the dopamine pathways that are affected by Parkinson's. And folks who have Parkinson's disease or Parkinsonism will have visibly decreased activity in those areas of the brain on a DAT scan. And folks who don't have Parkinson's disease or Parkinsonism will have a normal DAT scan. So that's one, and it can be very helpful, and it's fairly sensitive, meaning if you have Parkinson's, it should show up on the DAT scan. Although I have had just a couple of patients where their primary symptom is tremor, and I'm pretty sure they have Parkinson's, but we're getting the scan mainly for their benefit to help them um, come to terms with the diagnosis, and then they come back with a normal DAT scan. And it's hard for me because clinically looks just like Parkinson's disease, but your DAT scan's normal. And I think it's just because those pathways are so minimally affected for those patients, and it just doesn't show up yet on the scan. There's also now a skin biopsy that you can get, which looks at the pathology that um, uh, causes the Parkinson's disease. So it looks at this abnormal protein called alpha-synuclein, and then that protein aggregates, and then you get what we call Lewy bodies, which are the fundamental basis of Parkinson's disease. So the skin biopsy is also a sensitive way of helping to answer the question, are we dealing with Parkinson's disease or some form of Parkinsonism, or not? The skin biopsy, I will say, a DAT scan will be abnormal in just about all forms of Parkinsonism, including Parkinson's disease, atypical Parkinsonisms, of which there's a few. There's multiple systems atrophy, progressive supranuclear palsy, dementia with Lewy bodies, corticobasal ganglionic degeneration. These are all conditions that look like Parkinson's initially, but then over time they progress differently. Typically, they progress more rapidly, and they don't respond as well to levodopa as run-of-the-mill Parkinson's does. All of those conditions, with the exception of drug-induced Parkinsonism and vascular Parkinsonism, which is caused by strokes, all of those conditions will show up with an abnormal DAT scan. With the skin biopsy, only those atypical Parkinsonisms that have that abnormal protein, that abnormal alpha-synuclein, only those conditions will show up abnormal. So Parkinson's disease, dementia with Lewy bodies, multiple systems atrophy, those things will show up on the skin biopsy, whereas progressive supranuclear palsy will not. Corticobasal ganglionic degeneration will not, because that's a different protein abnormality. that those conditions will show up on a DAT scan, but they will not show up on a skin biopsy. So those are the tests that are out there right now to that are commercially available to help with the diagnosis.
Randy, we have a lot of questions, but that brings up the question. The research with dogs smelling Parkinson's has been very accurate. It seems to me, is there something in there? When I was diagnosed, there was really no way of knowing whether the Parkinson's or not. And you had I think five symptoms to be diagnosed with Parkinson's at the time. But
Yeah.
with dogs smelling, smell Parkinson's, it seems like maybe you should have a dog in the office.
Yeah, I've heard of the research suggesting that, strongly suggesting that there is a certain degree of sensitivity in terms of, picking up Parkinson's either through some type of pheromone or something that patients who have Parkinson's disease may have. I'll be honest with you, I don't know how sensitive and specific it is, and I don't know all of the science behind it.
Yeah.
But it is another biomarker, as we say, when looking to make the diagnosis. It is another potential biomarker.
Yeah.
So we have a question from Karen. She says, "Hello from Kentucky. Thanks for coming,
Oh,
Karen, from
wow.
Kentucky. I'm interested about your knowledge about the new under the skin medication through the attached pump. Thanks."
Yes, yeah, Vaylev, I think it's called.
Yes.
So I just had my first patient this week actually come in for counseling on Vaylev. We had the rep there and we came up with the settings. So I don't know how she's gonna respond to it yet, but I'm really hopeful. I think it's one of the most exciting pieces of technology and pharmacology to come on to the market in a long time. I mean, there's lots of exciting stuff that's been come out, um, and we're always looking for new treatments, but this particular one, I love. It's great because there has been. So what it is, Vaylev is a pump and it is hooked up to a cannula that is inserted into the skin. And then that pump pushes levodopa continuously into the skin. And so it gets absorbed um, through the skin, under the skin, rather. And its purpose is to help folks who have tons of fluctuations throughout the day, much like DBS does. And it helps, keep those levels steady, and it can dramatically increase the amount of on time that someone has. And in this particular instance, one of the reasons I wanted to use it specifically for this patient as well is they have such a difficult time with the oral medication. So whenever they take the medication, it has it gives them a lot of stomach problems that is not just a result of the impact of the medication on the brain. And so the fact that we're now able to bypass that, the gut, in terms of getting the medication in the system is, I mean, I'm thinking it's going to be a game changer for some folks, or at least I'm hoping, and it would eliminate too that need for timing of your medication around meal times because protein doesn't come into play because the gut doesn't come into play. It just goes right into your bloodstream from subcutaneous. So I think there's a lot of possibilities there, and I'm really excited to work with it. We prior to this, there is another pump called Duopa, where they pump levodopa gets pumped continuously into the stomach, or really technically the small intestine. And so you have a tube that goes from your abdomen into the stomach that has to be surgically implanted. And it's been around for a long time, or for a while. And that also addresses the fluctuations, but you've got to have that thing implanted surgically. And there's, potential complications there, and a lot of folks just don't like the idea of having a tube. So at any rate, this new device, I think, can, mitigate a lot of that concern. So I'm very excited about it.
Well, and we did have a follow-up question that also came with that for someone who'd been diagnosed for 25 years and take 4 25-100 carbidopa levodopa a day, and they were wondering about the pump being a good option for them. So
How much carbidopa levodopa did they say they take?
4 whole 25-100s.
Okay, so not a lot for someone who's had Parkinson's for 25 years. That's great. Um, so it depends, are they having problems, with the oral medication, just the mechanism of getting the medicine into their system orally. And are they having a lot of fluctuations, a lot of wearing off, and a lot of off time on that regimen? I will say taking it 4 times per day, even though it seems like a lot relative to most folks who've had Parkinson's for a long time like that, it's really very little. That frequency is relatively small. So, if you're experiencing a lot of wearing off in between doses on 4 pills a day, there are other ways to potentially address those fluctuations before you go to a subcutaneous, um, this subcutaneous infusion. But it just all depends on, why are you on 4 pills a day? Is there something that prevents you from taking more doses than that per day? Is there something that prevents you from adding an extender, a levodopa extender, to help make the levodopa last longer, that sort of thing?
Our next question is about dopamine agonists. Curious if dopamine agonists are still being prescribed as an initial med treatment. Are there any concerns about long-term use and or coming off these medications?
Yeah, this is a really good question. So, again, when I started treating Parkinson's disease, I was taught that early on, if a patient had moderate symptoms, that you wanted to put them on dopaminergic medication, particularly if they were relatively young, meaning younger than the age of 70. Um, you want to start with a dopamine agonist as opposed to levodopa, just to, you know, stave off or delay the length of time that you keep somebody on levodopa for. That thinking has changed for a couple of reasons. One, our fears about long-term levodopa have been, we've adjusted that. And if I feel like somebody needs to be on dopaminergic medication and they're having a lot of rigidity, if they have rigidity, and I'm gonna start with levodopa, and I don't care how old they are. When in the past I would start with a dopamine agonist like pramipexole, ropinirole, Nupro, which is the patch, or the rotigotine patch. Um, and the good thing about the dopamine agonists is that they have a long half-life, so they stay in their system longer, in your system longer than levodopa does. And they can lessen the amount of levodopa that you need to treat your symptoms. And in many instances, they can be used as monotherapy, meaning without levodopa. The problem is that they've got a lot of side effects, and they've got some very serious side effects that to we've come to realize over the past 10 years, I would say. Mainly, they can have a huge negative impact on cognition and behavior. And in particular, with male patients, for some reason, there can be a lot of impulsivity and compulsivity on these medications. And the impulsiveness and those behaviors can be quite destructive, where you can do sort of irreversible damage to your marriage, to your job, all kinds of problems. So that's one of the main issues. They also can cause some pretty profound sleepiness during the daytime, and they can, for some people, cause what we call sleep attacks, where you feel sleepy and then next thing you know, you're asleep, which is a problem if you're driving a car. And I have had patients crash their cars from sleep attacks because they think they can fight off that urge to go to sleep when normally you could, but on the dopamine agonist, for a lot of folks, you can't. You just go out. So that's another big side effect. And then as you get older, your tolerance for these medications becomes less from a cognitive standpoint because they can impact your memory and your thinking, and they can also cause a lot of hallucinations and delusions. And so you have to be really careful, and your older patients who are in their late 70s, early 80s, and older, you have to really be careful. So I'm much more reticent to use that class. I still prescribe them in certain situations. For example, if the levodopa is not working or there's a severe side effect that I think won't be so much of a problem with the dopamine agonist and I don't have any other options, I'll consider using a dopamine agonist in those situations. Dopamine agonists, when given once a day, can be very well tolerated and very useful for treatment of restless legs, for example. And those folks who take it just at bedtime, they can be really helpful.
We have a question about excessive sweating. Is that a symptom of Parkinson's, or could that be a medication side effect?
Great. Could be a medication side effect from levodopa, but it is a very common just Parkinson's symptom because Parkinson's affects the autonomic nervous system, which is the part of your nervous system that controls things like blood pressure, heart rate, it can impact bowel and bladder function and sweating. And it's very common for folks, and it's also very difficult to treat. But it's common for folks with Parkinson's to get what we call paradoxical sweating, where they sweat when they're cold. Or they just sweat for no reason at all. And it can be a problem during the day, it can be a problem at nighttime. But that's typically it's a result not so much of the medication, but of the Parkinson's itself.
Our next question seems to be the question of the month, which is Crexont. What do you think about Crexont?
Great question. So it's the newer form of levodopa, carbidopa levodopa. It's an extended release. It has both an immediate release and an extended release component in the capsule. So prior to that, we have been using Rytary for that purpose. And prior to Rytary, we had access to just extended release carbidopa levodopa XR, which doesn't work very well. But then Rytary came out, which does work well for a lot of patients, but not for everybody. But it does have a longer action to it. You still have to take it multiple times a day, but it does last longer for most folks than immediate release carbidopa levodopa. And in some patients, it's really delayed or prevented the need for something like deep brain stimulation surgery. And now we have Crexont, which is the data during the clinical trials suggests that it may actually work even better and give you more on time than Rytary does. I'm just now starting to use it. I would say, and most of the patients that I've put on it are folks that were already on Rytary. And I would say most of those patients actually have done better or feel like they're doing better on the Crexont than the Rytary. But that's not always the case. It's because it's so new, and we had the same issue with Rytary when it first came out. The dosing, it's difficult, or it's not difficult, but it's more challenging to figure out how to dose it. How to go from immediate release carbidopa levodopa to Crexont, or how to go from Rytary to Crexont. The milligram dosages are different, and the frequency is different as well. So with Crexont, you can start out twice a day, which is different from Rytary. Rytary, typically when I switch somebody from immediate release carbidopa levodopa to Rytary, I usually have patients take it, 4 or 5 times a day off the bat. And with Crexont, typically what you'll do is you'll start them on it twice a day. And then over the next week or so, as needed, increase that to 3. And I think 4 times a day is supposed to be the maximum. I can't remember if it's 4 or 5, but yeah, the results of it have been very promising just from my personal experience, which is relatively short so far, but I think it's going to turn out to be helpful.
I'm cognizant of your time and everybody else's time. I think we may have time for, do you have time for one more question? We do have
Of
about six,
course.
we have six backed up, so maybe,
Yeah, of course. Yeah,
are you
absolutely.
are you okay with maybe taking an email and we can help facilitate those folks maybe get an answer for the extra ones we might not have time for?
Sure.
Okay. The last one for today is, sorry, I whizzed past it. Is Parkinson's disease hereditary? I have two daughters. Will they get Parkinson's?
Great question. It's a really hard question to answer, but I have a pretty, pat answer that I give to everybody who asks this question. So the vast majority of people with Parkinson's do not have a family history of Parkinson's disease. So that says a lot. There are genes out there that are associated with Parkinson's disease. Most people with Parkinson's do not have one of those genes. And we suspect by and large that environmental factors come more at play than genetics does, or at least a combination of the two. And what those environmental factors are, by the way, we don't know. But there's going to be more than one. There's going to be more than two. But at any rate, so yes, there are genes that are associated with Parkinson's, but most folks don't have those genes who have Parkinson's. And just because you have one of the genes does not necessitate that you will get Parkinson's disease. So which, kind of calls into question for me, the utility of genetic testing for Parkinson's, and I'm sure I would get crucified in if I were trying to give a lecture, at NIH or at Hopkins or wherever. But I just, you need to realize that most folks with Parkinson's don't have a family history of it. And I do think environmental factors for most people play more of a role than genetics do. Should you worry about your daughters? I would say no. They do have a slight increase in risk for Parkinson's, but they still probably will not get Parkinson's disease, statistically speaking, if that's helpful.
Well, let me say that I've jumped in 23andMe, and I have no evidence of any gene factors of having Parkinson's for over 40 years, and we're all so different, and there is no recipe for what causes Parkinson's.
And that says a lot, Carl, because you were young onset when you got diagnosed.
I was 23.
And to still not have a gene for it,
Yeah.
that really speaks towards, some environmental factor out there that must have been related.
Yeah. So I showed signs at 17. So
Mm.
yeah. But
Well, yeah, sorry, Carl, to interrupt.
no, I was just say.
I just wanted, go ahead.
But there's signs of it skipping generations. It's signs of there's signs of someone I a distant relative have something similar to Parkinson's, but it wasn't diagnosed as Parkinson's.
Right.
There's so much we don't know, but we do know, right?
Yep.
The mystery continues. Well, thank you so much, Dr. Stephenson, for being
Yeah.
with us today, your time.
Thank you.
There were about 4 or 5 questions we did not get to in the chat, so we will work with Dr. Stevenson to get some answers together. We've got your all's email addresses, so we'll get those out to you. And we really appreciate your time today. You're making your time available to
Well,
us.
thank you.
Well, thank all the people who came.
Absolutely. Thank you for your time.
Well,
Also,
hopefully it's
this
not.
Wow.
session has been recorded and it will be in the Parkinson Social Network YouTube library because there's a lot of information in case anyone wants to, listen to it again. I'm sure Angela it'll be in a future email to direct you to being able to see it if you'd like to do that.
Absolutely. We'll make sure we get it out there,
Great.
and hopefully this isn't the last time Dr. Stevenson will be so generous in answering all our questions. I'm sure we could go for
Absolutely
days.
not.
Thank you very much, folks. Have a wonderful rest of your day.